Good afternoon. My name is Elise L. Conan Goldberg. On behalf of the Lung and Heart-Lung Transplant Patient Family Advisory Council, I would like to welcome you to our 5th Virtual Education Symposium. Today's symposium will focus on the intricate relationship between heart and heart-lung transplantation and the subsequent impact on kidney health. While transplants have become increasingly successful, it is crucial to address the potential consequences and intricacies that can impact the health of our other vital organs, particularly the kidneys. Before we begin, please note that you can use the Q&A icon on your screen to submit any questions that you might have during the webinar. We will try to address them as time allows. If questions are not answered during the webinar, we will forward them to the speakers, and hopefully they will respond to you directly. I extend my heartfelt gratitude to all the speakers who have contributed to the success of today's symposium. Please welcome our first speaker, who most, if not all of you, know very well, Dr. Gundeep Dhillon. He is the medical director of the Lung and Heart-Lung Transplantation Program at Stanford and an associate professor of pulmonary and critical care medicine. Dr. Dhillon will speak about the Lung and Heart-Lung Transplant Clinic as we enter 2024. Welcome, Dr. Dhillon.
Thank you, Elise. And again, I want to thank Elise and PFAC for inviting me and for all the attendees and thank all the attendees for joining. Happy New Year, everyone. I just want to give like a couple of updates. Our program is continuing to grow and continue to do well. This in calendar year 2023, we did 85 transplants, out of which 12 were heart-lung transplants. So these numbers put us in probably in the top 5 programs in the country. And when it comes to heart-lung, we are by far the largest program in North America. So we are very proud of that. With this growth, obviously there are some challenges, and the challenge I think you all feel the most is our clinics. Both Julia, I want to thank both Julia and Amy. They have been real good partners, and they have been advocating for more staff. And as a result of their efforts, we are up to 9 post-transplant coordinators and 12 nurse practitioners. So I'm hopeful that with more number of coordinators and higher number of APPs, we can have more availability in the clinic, but also, be able to available to you all over the phone and over my health app, so the number of visits can be reduced. So that's something we're going to focus on. As far as getting more space, I don't see that we'll be able to get more clinic space in near future. By near future, I mean next couple of years. I do think we are going to eventually, I do feel that eventually we are going to get clinic space in Blake Wilbur building, which is the next to the cancer center, if some of you know that building, but I think that's at least a couple of years away. The other changes which are beyond our program, but which do impact our program, especially on the pre-transplant side, in March of 2023, the UNOS changed the way the organs are allocated. They have gone to this thing called continuous allocation scoring system, which I think overall has been a net positive. But one thing it has really done to most programs, now we are getting good offers, organ offers from all over the country. Previously, if you would ever get an offer from East Coast, that meant that those organs have been declined by multiple other programs, and there was very rare that you would get a good quality organ from across the country. And that has clearly changed. And as a result of that, most programs are traveling more, but I think in some ways, again, we are fortunate and that our hospital system has been a great partner in this. we are not limited by resources as far as when it comes to flying all over the country to get organs. So we are very aggressive about that. And I think we are one of the programs which are traveling the most to get good organs. But it does stress the system as far as, especially on the pre-transplant side and on the surgical side, there's a lot more logistical challenges and a lot more flying around the country for organs. But I think on the net, this is a positive development that we are able to get access to good organs for our patient. So I'll stop there. These are the couple of things I wanted to bring up about our program. I'm hopeful that we'll continue to grow and try, and more importantly, continue to do these things well. I'll stop here. I'm happy to take questions, but if there are no questions, I want to thank Dr. Ahern for joining us. So I'll stop here.
Thank you so much, Dr. Dillon. We're going to grab the questions at the end just to make sure we get through all the speakers. So next, we're going to hear from Claire Reichley, who is one of our wonderful adult lung and heart-lung transplant coordinators. Claire will be sharing with us updates and news from the Lung and Heart-Lung Transplant Clinic. Welcome, Claire.
Hi, thank you. Like Lee said, I'm Claire. I'm one of the post-lung transplant coordinators. From here, I actually started about 6 years ago. So starting my 6th year this year, started in 2018. So I've probably seen a lot of you guys along the way. Like Dr. Dillon said, with 85 transplants last year, our program continues to grow. We got a 5th coordinator a couple of years ago, and with the numbers continuing to increase, we actually just hired a 6th post-transplant full-time coordinator. So we've had some, shifting with our staff. As some of you may know, Tamara, one of the post-transplant coordinators, moved to the pre-transplant side, which opened up a position that she had. And then Sandy, who had covered Ellen's maternity leave, took Tamara's spot. And then we got the 6th position approved, and it was actually just filled with Tojo, who is one of our relief transplant coordinators, who some of you may have seen in clinic. So he is actually starting this coming Monday as our 6th full-time post-transplant coordinator. So that will mean we'll have some shifting with some coverage. So just know in the near future, you possibly could have Tojo as a new coordinator, just as we kind of shift the number so that it's more equitable with everyone. So like I said, so that'll make 6 transplant full-time post coordinators, and the pre-transplant pre-transplant team, has 3 coordinators. And then just a reminder with clinic, we still just have the 9 and the 10:30 time slots, like Dr. Dillon said. No changes to clinic quite yet. Just a reminder in general to make sure you're showing up to the hospital with plenty of time to get your labs and x-ray done prior so that you can still check in on time. And just know that those are time slots. Everyone's either assigned 9 or 10:30. And with the high volume of patients that we have, we're trying, our best to see as many patients, as efficiently as we can. But we want to make sure that everyone is having, all their issues addressed while we can in clinic. And then just a general reminder, it is full flu, COVID, RSV season. So make sure that you're up to date with your vaccines, and then make sure you're wearing your mask anytime you're in public, avoiding sick people. Make sure you're reporting any symptoms that you may be having, respiratory or otherwise, to your nurse coordinator so we can work on getting you assessed. A lot of these viruses we treat with certain medications, others we don't. But just like any infection can trigger rejection episodes. We really want to keep a close monitoring. If you've had a recent viral infection or any respiratory infection, with plans to see you in clinic to diagnose what you're having, and then a close follow-up to assure that your pulmonary function status has remained stable. So, don't ever hesitate to reach out to your coordinators. Again, there will be some shifting here shortly, but we're all here for you as we continue to expand. There's going to be 6 coordinators, then you can most certainly get a hold of one of them, or we have 2 wonderful patient care coordinators who also are always available to help kind of triage things. So don't hesitate to reach out. That's about all I have.
Thank you, Claire. I know we all really appreciate those medical reminders for sure. And we will look forward to seeing you in clinic. Our next speaker is Dr. Patrick Ahern. He is a nephrologist and a clinical assistant professor in the Stanford University School of Medicine Division of Nephrology. He specializes in providing innovative care to kidney disease and transplant patients. Dr. Ahern's presentation will be on kidney health post-transplant. Please welcome Dr. Ahern.
All right, thank you everyone for having me. I'm going to share my screen. and hopefully get started. So thank you again to the organizers and to Elise and to Claire and everybody for inviting me. This is really nice to come and talk to the group about something that I know a lot of people worry about and think about, and it's vexing, and hopefully we'll all be able to learn something and answer some questions about kidney disease after lung and heart-lung transplant. As Elise mentioned, I am a clinical assistant professor here at Stanford. I've been at the university now since 2019, so I just hit my 5-year anniversary this week, and came here as a transplant nephrology fellow and then joined the faculty as a transplant nephrologist. I am the medical director of the living donor program in our transplant clinic, which we'll talk a little bit about as we go through our slides today. So here is what I would like to talk about today. We'll go through a brief overview of the kidneys. We'll talk about measuring kidney function. We'll go through major causes of kidney disease, frequency of kidney disease after lung transplant, causes of kidney disease after lung transplant, principles of kidney disease management, and kidney transplant after lung transplant. And then I think we'll have some time for questions to go over anything that we didn't get to during the presentation. So let's talk about the kidneys. We have 2 of them, just like there's 2 lungs, 1 heart, 1 liver, 1 pancreas, and then 1 set of intestines, but 2 kidneys, and it's because they're a little bit exposed to the outside world, and the backup is necessary. Their job is to maintain homeostasis on an overarching level. I think that homeostasis is kind of a lot of organs function, but the kidneys, that is their primary function. And what they do is to maintain a consistent electrolyte and fluid balance to keep our bodies consistently functioning. So our bodies work best in a steady state with things circulating in the same manner, with the same pH, the same amount of liquid in your bloodstream and in your cellular membranes and in your cellular systems. And it's really important to have a very steady level of electrolytes, especially sodium and potassium, to keep our cellular machinery working as well as possible. The kidneys clear waste products. They help to control blood pressure, and they do produce some hormones. Every organ has a little bit of multifunctionality. So I like to kind of think of the kidneys as a water treatment facility combined with maybe a chemical factory. That's what we have here. But if there's an earthquake, the kidneys don't quite handle things so well. They're a little bit fragile compared to other organs. And this is because the kidneys really need to be maintained in equilibrium, and they're really sensitive to changes in homeostasis and changes in inputs. So let's go through how we measure the kidney function, then we'll get into what causes dysfunction in the kidneys. Basically, when we say we're measuring kidney function, what does that mean? When we're measuring lung function, we're measuring how well the lungs are exchanging gases and how well the heart is pumping blood. With kidneys, we want to measure the amount of blood that the kidney is successfully filtering and turning into urine, essentially. The most important way to measure this, and probably the easiest, and the way we don't always think about, is really to say, is a person making any urine? If somebody is not making any urine at all, then we have a good sense that the kidneys are not functioning well. But we can also use other measures to get a more granular assessment of kidney function. What we want to look at is the glomerular filtration rate. The glomerulus is a structure within the kidney. And if you look at your lab results, in My Health, you often see a number that says the eGFR, the GFR. That's what we're looking at on our side. In addition to your creatinine, they kind of move in an inverse way. When creatinine increases, eGFR goes down. And that's because creatinine is a protein that's made in a constant rate in our muscle tissues. It then kind of filters through our body, gets to the kidneys and is cleared by the kidneys at a constant rate without coming back into the body. So basically what we know is that when creatinine gets into the kidneys, it kind of goes away at a constant rate. And that means that we can measure creatinine levels in the blood and get an estimate of how much blood is going through the kidneys, how much filtering is being done. So I think that's how that works. There's another protein that we started using a little bit more in the last few years called cystatin C. It works in a similar way. This is a protein that's made in the liver rather than the muscle. And in a similar process, it gets to the kidneys, is filtered by the kidneys, and should be kept at a steady state in our bloodstream. So we know if it's too high, it means the kidneys aren't functioning as well. If it's low or normal, it means that the kidneys are working well. There's other, maybe a little bit more accurate and more continuous ways to measure kidney function. One thing we can do is to collect urine for a certain amount of time and say, this is how much creatinine is in the urine. We can then use that number, combine it with the amount of creatinine in the blood, and get a more extended assessment of how much creatinine is being cleared. This is a little bit of more individualized test. It's not based so much on epidemiology. And then rarely in our world, we do a more direct measure of kidney function where we inject dye into somebody's bloodstream, and then we measure how fast that dye clears through the kidneys. This is something that I don't think would very often, if ever, be done in most of our patients, but it's something we do in people who are thinking about donating a kidney, which we'll get to in a little bit later. So measuring kidney function, just like measuring lung function, measuring heart function, is not something we can only do once. It's something that we need to know the trend about. Is the creatinine steadily changing? Is it high and staying high? Is it low and staying low? It doesn't really tell us very much as kidney doctors to see one change in creatinine levels. We kind of need to take everything into context. So when we're looking at our lab reports and we see, oh, my creatinine has gone up a little bit from a week ago, if we contact our doctors and our nurses and nurse practitioners, the most common answer is probably going to be, well, let's check it again and see if it's still changing, because that's going to give us a lot more information than just that one-off marker. Another really important measure of kidney function in the nephrology world is whether there's any protein leaking into the urine. Our kidneys are designed, and they're designed to kind of stop any protein from crossing from the blood into the urine. And when the kidneys start to get a little bit damaged, then we often see some protein spillage. And again, as kidney doctors, we like to look at how much that protein spillage, how much that protein spillage is. Is it changing? Is it consistent? And again, so sometimes you might see the urine protein to creatinine ratio, for example, on your lab tests. It might be something that your team orders to be checked. The kidney is just like honestly, every organ in our bodies. There's lots of different microscopic structures that work best when the rest of the body is healthy. And they work together to clean the blood, make urine, maintain homeostasis, like we said before. If we catch kidney injury early, a lot of the time it can be reversed before the small structures turn to scar tissue. But just like scarred heart tissue, scarred lung tissue, there's no there's no physiologic or biologic way to regenerate healthy kidney tissue once that scar tissue forms. This is something that's being researched across every aspect of health, is how can we reverse scarring of tissue that wasn't supposed to be scarred in the first place, or isn't ideally scarred. So major causes of kidney disease, regardless of lung transplant non-lung transplant. These are really what affect the kidneys. Impaired blood or oxygen flow, diabetes, the #1 cause of kidney disease in America. Medicines or toxins that are damaging the kidney. So in our talk today, this is something that's really important. We'll get into immunosuppression, how they affect the kidney in a little bit, but that is obviously at the top of our minds after any sort of solid organ transplant. Autoimmune disease, especially those that might be affecting the lungs and the kidneys, are something that we're going to think a lot about. Uncontrolled hypertension is not good for the kidneys. If there's too much pressure going from the bloodstream into the kidney structures, we can get that scarring to happen over time. And then lastly, obstruction of urine leaving the body. If the urine gets backed up, it kind of backs up the whole plumbing system, and that can lead to kidney damage. The list of this order is kind of from what's called pre-renal states to intrarenal states to post-renal states. So the impaired blood and oxygen flow is often considered a pre-kidney state, whereas the kidney is not getting what it needs. The middle columns I mentioned here are issues that are happening inside the kidney itself. And then the last aspect is something that happens after the kidney does its job, but backs up into the kidney. Kidney disease and lung transplant. It is pretty common, and it's mainly the most common kidney issue is an immediate acute kidney injury right after the transplant. A lung transplant is as everyone here knows, is a very major surgery, among the biggest that anyone can have done. There's bypass that happens, there's oxygen changes, the kidneys go through quite an ordeal whenever anybody gets a lung transplant. So this figure here is from a review paper published in 2019. It shows about 50% of people have a significant acute kidney injury event after their lung transplant. In the same paper, they reported that about 5 to 10% of people actually need dialysis, at least temporarily, after a lung transplant because the kidneys aren't working. If we go, I'm going to go back a slide. Acute kidney injury is kind of this first topic here, impaired blood or oxygen flow to the kidneys. That's what causes the acute kidney injury in most situations. So if we can reverse that, we get the kidneys reperfused, doing well before any scar tissue sets in, then oftentimes acute kidney injury resolves and we have healthy kidneys again. And this is evidenced here, which is one of the more recent papers that I know about. And this is actually something that I worked on when I was a fellow. And we'll kind of get into what the main findings of the paper were. But what we showed is that when people leave the hospital after a kidney transplant, most people have that eGFR number around 80, which is a really good number. As a kidney doctor, if somebody says my eGFR is 80, I would say you don't need a kidney doctor. That's a good enough number where you don't need to come and see us. And so that's the average number when people are done with their lung transplant. They're going home. They're getting they're going to get their outpatient lab set up and coming to clinic at 9 and 10:30 whenever they can make it. And again, this eGFR is probably better than it was at certain points in the hospital when that acute kidney injury event happened. So it's important to know that kidneys can get better, but they don't always. This is an epidemiologic study that was published about 20 years ago now about the progression of kidney disease after non-kidney solid organ transplants. So I hope you can see my mouse, but if not, the dark brown line at the top, the second from the top, is the rate of progression to kidney disease to an eGFR less than 30 over time. Okay. In this study, that was called chronic renal failure, which is an older term that we don't use so much anymore. Now this would be called CKD stage 4. So chronic kidney disease stage 4, which is the yellow line, the brown line was liver. So the yellow line is what we're looking at for lung. If we look at 5 years, it's about somewhere between 15 and 20% of lung transplant recipients at this time develop CKD stage 4 by 5 years. And that number kind of slowly increases as we get to 10 years, maybe up to 20 to 25%. I would imagine that those numbers are still pretty much the same today. I don't think they've changed too much, but I looked and I looked and I couldn't find a really good updated epidemiologic outcome from this. I think that this paper kind of established the baseline, and it hasn't been researched yet. Maybe something we could think about doing on our side in the future. If you look compared to the other organs, I think that lungs kind of here in the middle. Liver transplant recipients really had a little bit higher risk of CKD. Small bowel transplant recipients had the highest risk of CKD. And then 20 years ago when this was done, heart-lung patients were having a little bit lower risk. There's a lot of confounding information here, and practices have changed, medications have changed, so I don't want to guarantee this is still the same today, but I bet it's plus or minus 10% still. What are the causes of kidney disease after lung transplant compared to the causes of kidney disease, in the general population? So like we said, the peri-transplant, so acute peri-transplant, acute kidney injury, that post-operative kidney dysfunction can persist and lead to chronic kidney disease. Calcineurin toxicity is probably the big one that we think about. That's at the top of our minds all the time when somebody has been on tacrolimus or cyclosporin for a number of years. Diabetes, it's, again, like I said, the #1 cause of kidney disease in the United States. Diabetes on top of calcineurin, on top of acute kidney injury, it just makes things more likely to happen. As we know, that diabetes is also something that can happen after the transplant. We can have new onset diabetes, especially due to steroids and the calcineurin inhibitors. They all add a risk for diabetes happening. And then infections, other medications, low blood pressure can have additive acute kidney injuries that eventually lead to chronic kidney disease. And finally, in the lung transplant world, especially the condition scleroderma is known to cause kidney disease in addition to lung disease. And there are other potential co-conditions that can happen. Symptoms of kidney disease. This is a tough one, where other organs, you can have signs of dysfunction that you feel. The kidneys don't really tell you that they're not working until sometimes it's pretty late in the game. Often it's even vague or absent. So relatively early in certain people, new frothy urine, that can be a sign of a lot of protein in the urine, which, like I said before, is something we would worry about as kidney doctors. New swelling in the legs that's not explained by the heart or the liver. When someone has new swelling, we always look at the urine to look if there's protein, because that can cause that too. Unexpected worsening, hard to control hypertension could be associated with some burgeoning kidney disease. Not always the case, though. Hypertension is so common and caused by so many other issues. I wouldn't jump to kidneys when you see that, but something your doctor should always look for. And then fatigue, it's vague and caused by a lot of different comorbidities and problems, but definitely associated with kidney disease. Very late kidney disease, when somebody might be about to start dialysis, that's when symptoms really are common, and we're looking for them, because as I'll mention now and again, we don't want to start dialysis until someone's going to benefit from it. And benefiting really often is symptom relief, where we don't love to treat numbers. No doctors love to treat a number. That's not how we want to practice medicine. It's not a paint by numbers approach. The numbers mean a lot, but we want to treat patients individually, and we want to do the right things for people. So the symptoms of end-stage kidney disease, where your doctors are going to think about dialysis or transplant or having a really long conversation about what to do. It's unusual difficulty sleeping or somnolence, maybe staying really trouble getting awake and staying asleep. A metallic taste to the food is a classic sign of end-stage kidney disease. Anemia that's requiring high doses of medicines to address. Decreased urine volume, so you're peeing maybe once a day and it's not as much as before despite taking Lasix and diuretics. And then swelling, edema in the legs, edema in the heart, edema in the lungs that doesn't respond to diuretics like it used to. Those are all signs of late-stage kidney disease, in addition to the lab work that we're looking at, of course. So how can we manage kidney disease? This is why we have nephrologists, hopefully, your pulmonology team, they're all trained internists. They did a lot of nephrology work during residency and medical school and in their jobs. Everyone's looking at creatinines. Most doctors know what to do about an acute kidney injury without calling us, and we trust, and we're always available for help, but we don't always need to be helping. However, once kidney disease progresses to later stage, then getting nephrology involved for close monitoring and planning and optimization is a good thing. If somebody asked me for broad guidelines, I would say that someone should always have a kidney doctor if their EGFR is less than 30, which is that CKD stage 4 group, or if they have other stages of CKD with persistent protein in the urine. But those are kind of enough reasons for anybody to have a kidney doctor, as well as somebody who has a sudden and sustained and unexplained decrease in kidney function that we just don't know why that happened. I would recommend earlier referrals in complex patients like lung transplant recipients whose kidney function is lower than expected, because again, having a second set of eyes on everything and seeing what we can do to reverse and minimize progression is a valuable position to have. Okay. Management of kidney disease. What can we do about it? We don't have oxygen therapy for the kidneys. We don't have as many great treatments as we wish we did. But there's some treatments, and actually they've gotten better recently in the last 2 or 3 years. There's a new class of medicines that's been really beneficial that anybody with kidney disease should at least have heard about, and we'll get to that. We should identify reversible causes. That's, like I said, if you can reverse a decrease in GFR, glomerular filtration rate, before scar tissue sets in, then we can get the kidneys back to working well, and maybe you don't need your kidney doctor anymore. We want to minimize or eliminate toxic medications as much as we can. We want blood pressure to be low and good and at goal. We want to get rid of as much of that protein that we can. And then we want to monitor for progression and see what's changing. And lastly, it's important to prepare for end-stage kidney disease if things are heading in that direction. Dialysis and transplant are things that are best planned for and not treated in the emergency room or in the acute care hospital setting. And that's something that nephrologists are expert at working on and working to plan and getting patients ready for. Potentially reversible causes, what are some? So autoimmune disease, we have a lot of great treatments for new autoimmune diseases now. Toxic medications might be identified and eliminated. That outflow obstruction could be identified and addressed. If somebody has a kidney stone or a prostate that's so big it's blocking urine outflow, we can treat that. Inadequate blood flow to the kidneys may be due to dehydration or solute intake. If we can reverse that before scar tissue sets in, we can get the kidneys back to working well. Sometimes we do a kidney biopsy where we get a sample of the kidneys to really get a look inside of them to say to ourselves, what's going on here? Is there something we can reverse? Is the scar tissue already there? Is there an infection in the kidneys? Is there an autoimmune condition happening that we can give some treatment for? Toxic medications, that's going to be on the top of this group's minds because there's a lot of medications after a lung transplant. Those are really important. Sometimes certain people have allergies in their kidneys to medicines. They don't have allergies in other parts of their bodies. Nephrologists know to look for this, and they will look at your med list, and we kind of have a sense of which medicines often do this, and we'll know how to look for it. And then some medicines are just universally, unfortunately, tough on the kidneys, especially calcineurin inhibitors at high doses. Valsite is another one. Bactrim can raise creatinine kind of in a different mechanism. It's not necessarily bad for the kidneys, but it's something we'd look for. And then I think that no solid organ transplant group is recommending NSAIDs for their patients, but ibuprofen, naproxen, and domethacin, these are medicines that your kidney doctor is going to ask if you've been taking, have taken, and recommend avoiding as much as possible. And then certain other antibiotics that people usually get in the hospital that you wouldn't be taking at home. That's the other thing. Certain kidney disease can be worsened by some over-the-counter herbal supplements. We'll ask about those. It's not always slam dunk and not always a kidney alone issue that's happening. But if the kidneys aren't working well and you're on a lot of medications, it's always worth asking pharmacists, their doctors, XYZ supplement over the counter okay for me to take. We're happy to look things up and try to answer the best we can. I know on the kidney transplant side, our pharmacists are fast and knowledgeable and really happy to help with any questions like along those lines. I would say almost all of the data from the last few years tells us that there's no such thing as too low of a good blood pressure for the average person. No one wants people to feel like they're taking so many antihypertensive that they're getting dizzy when they stand up and they're losing energy. But if we can get a blood pressure to the 120s, low 120s over low 80s, that's probably better for your heart health, better for the kidney, as long as you're staying well hydrated. So we do think that getting the blood pressure to goal, if hydrated, is a good thing. And then there's certain blood pressure medicines that are associated with better term long kidney outcomes. People after transplant might have nausea, might have poor appetites, a little bit of anorexia, not eating very well. That's not good for the kidneys, not good for the rest of our bodies either, not good for recovery after the big lung transplant surgery. So it is important to maintain good hydration, but I really want to stress that there's no benefit and potential harm from drinking too much liquid. If the kidneys are declining and not working very well, we can't flood them back to life. That's going to actually make a lot of the electrolyte balancing harder to do. It can cause edema, it can cause worse outcomes. So what I tell people is if you're not getting enough liquid because you're nauseated and not doing well, then that has to be corrected. But if your calorie intake and your protein intake is good, you should drink to thirst. Our kidneys are pretty good at telling us how thirsty we should be, and our bodies are telling us that as well. There's no reason to try to drink liters and liters of water a day. That's not going to help the kidneys get better. That's what I say to patients who don't have kidney transplants. If somebody is going to get a kidney transplant, when that new kidney is all of a sudden working, we kind of tell them a little bit differently in those situations. But for somebody who's working on chronic kidney disease, there's a balance of, there's definitely a line where people can cross into drinking too much liquid. That can be a problem. We want to minimize the amount of protein in the urine. We have really good medicines like ACE inhibitors, angiotensin receptor blockers. So the lisinopril, losartan for the blood pressure also help lower the amount of protein in the urine. Spironolactone is another one a lot of people in this group might have heard of. Sometimes because we think that somebody has kidney disease from the tacrolimus or the cyclosporin, we try to minimize that, replace it with everolimus or sirolimus, and that goes well most of the time, but sometimes those medicines in particular can cause a lot of protein in the urine, which is a sign that they're actually causing a little bit more damage to the kidney than they're worth. So it's something that we all watch very closely when we make that switch. And then we should maximize medications that can slow kidney disease progression. The big ones I talked about, the lisinopril, the losartan, the spironolactone medicines along those lines have been around for a while. But there's a new class of medicines called SGLT2 inhibitors, which the cardiologists are prescribing to most of the patients with heart failure now. As nephrologists, we think that everyone with diabetes should be taking one, and there's more and more evidence that anyone with kidney disease who can tolerate the medicines probably is going to get at least a little bit of benefit if there's no bad side effects from them. So there hasn't been a study to date that I know about that hasn't shown a benefit from SGLT2 inhibitors. And the problem is that the mechanism for why they work so well is a little unclear. So we can't go out and say, okay, this is the group that needs them, this is the group that doesn't benefit. It seems that just about everybody with progressive kidney disease, especially if they have protein in the urine, they do seem to benefit so far. That said, none of these medicines are magic. Them slow down progression of kidney disease. It's really hard to reverse scar tissue, like I said. And so the goal is to prevent formation of more scar tissue, or at least make it as slow as possible. And then because we don't have the ability to reverse kidney disease in every situation, sometimes we have to plan for end-stage kidney disease. Kind of like I was mentioning, it's ideal and preferred and better for everyone if we can prepare for dialysis or hopefully transplant, but especially most people get dialysis before a transplant. We want to prepare over time in a controlled outpatient setting. It's better to plan to start dialysis next week than it is to start it in the emergency room at 2 in the morning. That's really traumatic and hard on people. When does dialysis start? You know, like I said, this is not a prescription that we can just say here, oh, your number has hit a certain threshold, it's time to start dialysis. It's really when symptoms are present. That's the most important thing. The symptoms we talked about before, the change in the taste, the edema we can't control, the really bad fatigue, the decreased appetite. When those symptoms are present and the GFR usually less than 10, somewhere between 5 and 10, that's probably when most nephrologists would start dialysis. We don't want to start early because dialysis, as I'll talk about in the next few slides, it's not fun, it's not easy, it's tough on everybody who's going through it. There's 3 big options, 3 big categories for treatments for end-stage kidney disease, and that's hemodialysis, peritoneal dialysis, and then kidney transplant. So hemodialysis is usually performed in a dialysis center 3 times a week. And usually it's about 3 or 4 hours. The nurses manage the care, patients show up, get their dialysis, and then it goes on. The downside is that it's associated with a lot of fatigue. It's a lot of time during the day to have done, and there's a faster decline in the residual kidney function. In peritoneal dialysis, this is the one that's what's usually what people do when they do home dialysis. Is you use a machine usually to get fluid into the abdomen. That fluid filters the body's fluid. We take the fluid out, and the body's fluid is cleaner and good enough to go on. It's something you do at night. It's a little less you have more time during the day. There's less fatigue associated with it. It's a little more gentler is how we consider it. The downside is that you have to do it yourself. Infections are possible, and sometimes it's not enough. Sometimes there's not enough cleaning happening in this way. Kidney transplant, that's, I think, our preferred option if possible. What happens is that somebody gets a third kidney, it's placed into the lower pelvis, attached to the blood vessels going to the legs, and then hooked up to the bladder. So basically you have 3 kidneys. People live longer after a kidney transplant compared to dialysis, and really a lot, and higher quality of life is the big benefit. If the kidney transplant goes well, you get to stop dialysis, and that's great. More energy, you have less time dedicated to your kidney care, it's easier to travel, etc. The downside is that transplant itself, that big surgery. Not everybody's healthy enough to go through a major surgery, and the kidney is not going to work if you don't recover from that major surgery. And so there's no benefit of doing a kidney transplant if that kidney transplant is just going to leave you on dialysis anyway. And then immunosuppression is restarted, higher doses up front, but then kind of weaned back to what it would be after the lung transplant.
Excuse me, Dr. Ahern, is it possible we're getting a lot of feedback?
Oh, sure.
Noise that's in your background. People are having a hard time hearing you.
Okay, yeah, 1 second.
Okay, thank you.
Sorry, 1 second. Let me just. Okay, sorry about that. It's just packing going on in the background. Okay. I was saying, so kidney transplant, there is lower risk of cardiovascular disease, higher quality of life, but you do have to go through that major surgery again and recover from it. So how can we get a kidney transplant? There's 2 types. There's deceased donors and living donor. So in a deceased donor transplant, a healthy kidney, it's donated by somebody who passes away, similar to a lung transplant. Only 2% of all, less than 1% of all people who pass away are donating their kidneys. It's just like lung. It's not easy to be a kidney donor because the person has to pass away in such a manner that the kidney is still healthy. But we're really lucky on the kidney side that living donors are possible. And this is when a healthy person donates one of their 2 kidneys after going through an extensive evaluation. They have to be physically and mentally healthy, and they can donate directly to a recipient or indirectly via a swap, which we can go through. Again, there's similarities to lung transplant and differences. The major similarities are there are more people in need than there are available donors. You need to find a match between the donor and the recipient. And then people need to take lifelong immunosuppression. The differences compared to lung transplant, kidney transplant is more common than lung transplant. So about 25,000 kidney transplants happen every year versus only about 2,500 lung transplants, maybe 2,600 in the last year. Living donation is possible, which is not possible with lung. And then priority is given based on waiting time rather than degree of illness for kidneys. And there's less antibacterial and less antiviral medicines needed after a kidney transplant compared to lung, although it's pretty similar in the early stages. So, there is a new program just for the last 6 months or so called the safety net. So if somebody gets a lung transplant and their kidneys are failing or near failing within the first year of that lung transplant, once they're healthy enough to be considered for a kidney, then they can kind of jump toward the top of the list of the kidney transplant list. And so that's really just taken off in the last year. It's been available for liver transplants now for a few years, but heart and lung just were added recently. This is the mechanism for people to donate kidneys to people who are not directly a match. It's called an exchange program. So if donor one and recipient one are family members or friends or acquaintances in some other way, but they're not compatible with each other, they can actually swap with donor and recipient two. And so what this means is that even though I can't donate to my spouse or my sibling, I can still functionally donate to them. These two surgeries happen at the same time. The donor surgeries happen together, then the recipient surgeries happen together. And so, you know, the donor still donates a kidney on the same day the recipient gets a kidney, and it seems as if you're still directly donating. This program, this has been expanding and expanding, and Stanford especially is doing more of them than we've ever done before. And it's really a great means for people to match a better kidney than they could have donated before. Another benefit here is that if somebody is older and wants to donate to somebody younger, even if they are a match, sometimes we can say, you know, we think this person needs a larger and bigger kidney than their donor has. We can find the right swap to make. So you don't, even if they're not compatible, if they're just not the perfect match, we can do it this way. This is a map of all the centers that participate in what's called the National Kidney Registry, where we can get the swaps from. So there's 4 in the Bay Area, there's 9 in Southern California, there's 3 in Washington, there's 1 at OHSU, just on the West Coast. You know, if we look through all of these numbers, there's a lot of centers are now participating in the NKR. It's the biggest of these swap centers, these swap programs. And then I just have 2 more slides about looking into the future for kidney transplant, and probably lung transplant too, but something that's probably going to start with kidneys because they're less size dependent and a little less need to be as perfect. Xenotransplantation, which would be engineered organs from other species suitable for transplant to humans. There's certain groups that are about to start studies on pig to human kidneys. They've done a few of these transplants to very select individuals at NYU and at the University of Alabama, and they've shown pretty good outcomes. This isn't quite ready to start, but the question to me, is it going to be like the California high-speed rail on the right here, or is it going to be something like the Shinjuku in Japan? Is it going to take off and this is going to be like cell phones where everybody has one, and you don't remember a time before you had a smartphone? That is my last slide. You know, I'm obviously here to take questions, but I'd like to, you know, acknowledge the inspiring kidney transplant team at Stanford. We have our 3 surgeons, our medical director, and then as we see our compatriots on the kidney side compared to lung, these are my living donor coordinators as well as our deceased donor coordinators. So
Thank you, Dr. Ahern, for your
incredibly
Thank you for your incredibly thorough, educational, and informative presentation. We do have some questions, but I think we're going to wait until after Maria Paula and then ask all the questions at the end. Are you available to stay on?
Yeah,
until 2:30?
Stay until right around 2:15, 2:30, but that's fine. Yeah.
Okay, well, maybe if you have time constraints, Bob, do you want to go in and jump in with a couple
let's
questions?
go ahead. We had a question from one of our attendees. Does diet affect kidney function before kidney disease is present? So we know diet,
yeah,
you know, we're always
does
told
diet-
about avoiding salt and things
Yeah.
like that. But before you have kidney disease, you know, does diet affect your course?
I would say it affects the course to the extent that it affects the course of anything. At very late stage kidney disease, we usually recommend a relatively low protein diet so as to not force the kidneys to stress so much. But earlier, before then, I don't think that diet honestly plays a huge role in kidney disease, as long as we're not eating too much salt and controlling blood pressure. So but high salts, high processed food diets, they're going to lead to systemic issues, or they're more possible to lead to systemic issues, diabetes, which could down the line lead to kidney disease, but nothing direct as far as I know.
Okay. And then there was another question about blood pressure. You know, we're always told, or, you know, we all know, you know, you want lower blood pressure. Hypertension is, you know, a bad thing, but it's possible to have your blood pressure too low for your kidneys' well-being.
Yeah, definitely. You know, if a lot of the time our bodies inside of us get used to a certain blood pressure. So if your blood pressure has always been 160 and all of a sudden you bring it down to 110 overnight, that might be bad for your kidneys. That could be a sign that your kidneys aren't going to get the blood flow they need. That can also be bad for your brain. The brain's probably more important than the kidneys in a situation like that. But if somebody's having a blood pressure with the top number, the systolic, in the 70s, 80s, and it's possible to get that closer to normal. From my perspective as a kidney doctor, I'd usually say if you could get that closer to normal, that might be a good thing. If on the other hand, that's where you've been living your whole life and your kidneys are used to a blood pressure that low, that might be okay. You know, there's some people that just have blood pressure that's 95 over 65 their whole life, and they're at very low risk of strokes. And if their kidneys have been perfusing well with that blood pressure, it should be fine. It's quite individualized. From an epidemiologic standpoint, from groups of people, we'd say around 120 over 80 is probably the global target we would go for.
Okay, I think, thank you. I think that's all of the questions we had from the attendees.
Yeah, I think I see a few more over here.
Do you, you might have, I see, yeah, okay.
I'll just go down from
Go ahead, yeah.
chronologic. So could you go out of state for shorter waiting times? I think that we recommend everybody who's on our list look at different waiting times at different centers if they can. Kind of similar to the lung allocation system, there's been a change in the kidney allocation system in the last few years, and waiting times have gotten shorter in Northern California, but they're still definitely shorter in other states. Not every center takes out-of-state patients, but the ones that do, we encourage people to get evaluated wherever they can if they can do that. There's no contraindication to that. Can a lung transplant person donate a kidney? That's a good question. Probably not, to be honest. I think that we would tell somebody who's had a lung transplant, as a living donor, is what I'm answering. As a deceased donor, that might be something to consider. But as a living donor, we would say because of the risk of the medicines you take and the possibility of the lung having issues and getting people sick, it would be healthier to keep both of your own kidneys. But people who are lung recipients can be advocates for other donors and say, you know, I can't do it, but my XYZ needs a kidney transplant. Do you think they could try to help? Optimal amount of fluid to drink daily before a kidney disease starts. Personally, I would never want to get a kidney stone, and I don't want to get urine infections. And so I wouldn't be drinking enough water to avoid kidney disease. The kidneys are a little bit resilient to that point if they're working well. But if you don't drink enough water and your urine is dark colored all the time, you might be at risk for getting kidney stones, and that's never fun. So if somebody asks me how much water to drink, I always say drink enough so that your urine is only light yellow to mostly clear after lunchtime and beyond, because that's a sign that your body that you're diluting your urine pretty well. But again, if you're drinking so much that you're getting swelling in your legs or swelling in your lungs or swelling in your heart, or your sodium is going down your labs, you're drinking way too much. So don't do that. And then that asks if she takes protein. I would not. Well, again, I would talk to your doctor. I mean, I don't know your whole medical history about protein powder, but I don't think that that's bad at all for the kidneys. If their kidneys are not near failing, protein is necessary to be healthy. Even if they are near failing, you need some protein. And so I wouldn't. Oh, I see. You had a kidney transplant and then you got a lung. Yeah. So with the kidney transplant, if it's going well, I would not recommend stopping the protein powder. I think that if it's working well for you, you should be a healthy person, you know, and I really commend you on your medical journey and taking such good care of yourself, and even thinking about sacrificing more of your diet than you do already. But my pretty strong recommendation would be to stay healthy and not stop protein, unless your doctors are telling you otherwise, the ones who know you better. But from a global perspective, you know, I don't think that anyone should try to go above and beyond in taking care of their own health.
Are there any more questions, Bob? Or that,
None that I see.
okay.
We've covered them all. Yeah.
Okay,
And
thank you,
again,
Dr. Ahern, so much. We really appreciate
of course,
participation.
and I apologize for the background noise. Hopefully people were able to get most of the presentation, but if there were more questions, feel free to reach out to me and I'm happy to discuss more or answer anything else.
Oh, thank you. That's a very gracious offer. We will follow up on that.
Okay, great.
Okay, have a great rest of your day.
I'll stay on for another 10-15 minutes, but if I might take off then.
Okay, sounds great. Okay. Our next speaker, Maria Paula Del Rio, will be sharing her perspective on living with kidney disease post-transplant. Maria Paula is a heart, double lung, and kidney transplant recipient. While managing her complex medical issues, she also has a full life working as a journalist, public relations professional, businesswoman, and international traveler. We're so excited to have Maria Paula here with us today and looking forward to hearing all about her transplant journey. Welcome. Thank you so much. You're on, Maria, you're on mute. So thank you.
Do you hear me well now?
Yes.
Okay. Well, you need to have patience with me because my voice is like this. During the transplant, I ended up having a tracheotomy that damaged my vocal cords, and my voice obviously was affected. But I give thanks to God because I still have a voice to tell my story. So it is a pleasure and truly a great honor to be here with you today, with patients that have lived in their own skin similar journeys than mine, with doctors that have been pillars of the life that I enjoy today, and with families that know everything about pain, suffering, joy, hope, faith, and faith in the future. And contrary to what you may think, my story is not the story of a hero that wins battles with his own fortitude. Truly, I don't feel there is merit on my side. My story looks more like the one of the paralytic at the gospel who was lifted by 4 friends and placed at Jesus' feet, climbing the top of a roof and opening a hole to drop his friend off because the house was packed and there was no way to enter. So seeing the faith of the friends, not the paralytic, the friends, Jesus healed the paralytic and say, take your stretch and walk. In the same way, I was lifted by thousands of people who prayed for me in the moments when I needed the most, beginning, of course, with my own family. If something, I am a witness of the power of prayer since the very beginning. I'm sorry. I was born in Colombia with a congenital heart disease. The day I was born, the doctors told my parents that I was not going to live more than 3 days. They saw me so blue, and back in Colombia, medicine was not at advance, that they thought the worst. Since that moment, since day one, my family began to pray for my life. And this is the only way I have to explain it. I was born with 7 different problems in my heart. It was dextrocardia, which is my heart, instead of the left, it was on the right side. Transposition of greater vessels, which means that what was on top of I mean, what usually is on top, my heart was at the bottom. What is at the front is at the back, to the point that my husband calls my heart my twisted heart. And I love that. I was born with interventricular communication, where the oxygenated blood that came from the lungs mixed with the non-oxygenated blood that comes from the body. And therefore my saturation was lower since day one. And due to this lack of oxygen over the years, I developed pulmonary hypertension. And the way I explained it to my friends is if you put fluid in a sponge, it works and you can wash dishes. But if you start to put oil, the sponge gets stiff. And that was happening to my heart, to my lungs. So anyway, my parent, what is incredible, and I give thanks to my parents, because I was never treated as a limited person. On the contrary, they asked from me exactly the same things as my other 4 siblings. Good grades at school, responsibility for my actions, to be kind and generous, to foster good relationships. And I grew up like that, with the certainty that I was able to do anything I wanted, even if it took greater effort to achieve it. Very little I learned quickly that when things are difficult to obtain, it is because they are even more valuable. So as you can imagine, I have been in hospitals my entire life. I've been in the Miami Jackson Hospital, Children's Hospital, Cleveland, Houston, Boston, Pittsburgh, Spain, you name it. I have a very international family and I have traveled for many years. So everywhere I go, I end up in the hospital. When I was 24 years old, we received a letter from Cleveland Clinic saying that the final solution to my problem was a double transplant, heart and lungs, because my heart was very ill, but my lungs were not strong enough to resist like a heart operation or heart surgery. And they told us that the longer we can wait, the better, because medicine was improving. And what we want is to have the transplant at the peak of the curve, with more experience and better medicine with active rejection medication. Finally, when I was, I'm sorry, my voice. So when I turned 38 years, I was already living in California with my husband. I woke up one day feeling ants walking in my legs. And immediately I called the doctor. That moment, I was Dr. Murphy, my cardiologist at Stanford, who explained to me, say, Maria Paula, what you have is cellulitis. And it was funny because I laugh and I say, oh, doctor, you tell me something else. I already know that, thinking that it was this like kind of orange skin that we develop with age. But of course, it was not like that. So Dr. Murphy explained to me that it was a bacteria, cellulitis was a bacteria that gets into the bloodstream very quickly and it immediately goes to the heart. And if it gets into the heart, that was it. So to fight these bacteria, they needed to begin a medicine that was delivered directly into my heart. And to that, they did a catheter all the way to my heart with the help of a portable X-ray. And that procedure was tremendously difficult because they couldn't find a vein and they tried for 4 times. So I started, at the beginning of the story, I started to see what was going to be this like. But as everything in life, there is always 2 sides of the coin, The moment was scary and painful, but at the same time, this medicine was precisely what placed me on the top of the list, which means that the first donor that matched with me, it was for me. And that was incredible. I didn't know where in the list I was. So I was in the hospital waiting for the donor. I was already not even 1 week. When Dr. Scandling with Dr. Dillon were seeing that my kidneys were working only 30%. And due to the lack of oxygen in my blood, my organs began to fail. So they came to my room and told me that after the transplant and with the new oxygenated blood in my kidneys, they would improve. But of course, that was not a guarantee. So they told me if later I need it, they will do a kidney transplant, precisely what the other doctor was talking to us about. And at that moment, honestly, it was more out of fear than anything, that knowledge or anything. But I was terrified. And I remember telling Dr. Scantling and saying, no, doctor, no, like if you're going to open me, because you're already doing surgery, if you're going to open me, take whatever you need to take off, change whatever you need to change. But I want just one transplant from one donor. And the doctors, and I honestly think, it was God who helped me, seeing that it was easier to be compatible with one person than with two. So after many days of studying, Dr. Dillon, Dr. Will, and Dr. Scantling decide to perform a triple organ transplant, heart, lungs, and kidneys. On September 17, 2011, a nurse was knocking at my door in the hospital at 2 a.m. to tell me, we have a donor. That day, with 38 years old, I had a triple organ transplant. And doctors were surprised because I had 100% match with the donor. And I can only attribute these to the many prayers that I received from all over the world. I have family in Australia, in Texas, in Miami, in Boston, in Ecuador, Colombia, Mexico. And there were, at that moment when I was interned to wait for the donor, I began a blog to tell all my friends what was going on in the daily basis. And there were many people joining the blog. I remember that it went from 5,000 readers to 50,000 readers within a month. And now it's like more than 300,000 readers that follow my blog. So I knew that, that this was because there were so many people praying for me. So my recovery was very long and difficult. I was almost 4 months in the hospital and 2 of them in ICU. And there were many setbacks. They intubated me. They took the tube and intubated me again 4 times because I was not able to breathe deeply and expel the fluids that remained on my lungs. I remember clearly the doctors asking Maria Paula, like, breathe deeply. And I was like, no, deeply. Like, you need to breathe the air and put it all the way into your stomach. And I couldn't, and I tried, and I couldn't. And I couldn't because, not because I didn't have the lungs, the capacity to do that, but more because for 38 years, I learned to breathe in a very shallow way. And I couldn't breathe because I didn't have like the chip in my mind. So at the end, to help me, I ended up having a tracheotomy. One night after many days without sleeping, because I think we all know that in the hospital, you don't get to sleep. I don't think doctors or patients get to sleep at home. So there were nights and nights without sleeping, with tubes coming out of my body from many different places, attached to 2 balls of medicines that my mom used to call the Christmas trees, because it looked like Christmas tree with all the ornaments. It was medicines and medicines and medicines. And I was exhausted. And of course, I was about to throw the towel, because in that circumstances, it's difficult to see the end. So I remember asking my mom and telling my mom, like, Mom, do you think I'm gonna make it? Because I thought, this is it. I'll be attached to a machine for the rest of my life, and that's it. But my mom, who is very sweet, I hope you meet her one day, she grabbed me by my arms and she took me like by my arms and she told me Maria Paula. And so when she say Maria Paula, it's serious, because she usually calls me my love, my honey, my crocodile, and different things. So she asked me like this, I remember it clearly, say, Maria Paula, why did Peter sink? Why did Peter sink? And maybe you don't know, there is a passage at the gospel when Jesus approached his disciples walking on water, and they were afraid, thinking that he was a ghost. So Peter asked, if it is you, command me to walk on water. And he did. Peter began to walk on water. It was incredible. But seeing the waves high and feeling the storm, he sunk. So my mom was asking me that time, why did Peter sink? Like, why did he sink? Because he doubted. And she told me, you and I, Maria Paula, we are not going to doubt. If we see that the waves are big and our boat is sinking and we have not, we are not going to doubt. And we may be feeling that we are being pushed into a cliff that is deep and dark and we don't see the end. Say, but we know that is God's hands. And she did like this, waiting for us at the bottom. She said, Maria Paula, we will jump. And I remember it because I have a photographic memory. And I remember seeing everything, the waves, the boat sinking, the cliff, the darkness, and I was feeling it as well. But I decided to jump that day. And I thought, if this is it, with all the needles, with all the pain, with days of white, without sleeping, sleep deprived, with all the suffering, with all the setback, if this is it, this is it. And if this is a way, I am going to embrace this. And I think there is a moment for all of us when we need to take a leap of faith. It's very different than living with resignation. It's more like embracing your life as it is, as it comes. In Spanish, we say like, tomar el toro por los cuernos, which means like taking the bull by the horns. Say, I can do this, because God is helping me. And, with faith in God, with faith in the doctors, with faith in the people that care for us, and obviously with faith in yourself. There is a moment when we need to have faith. I'm sorry. Today, I am here to thank all the doctors and nurses that were by my side long days and longer nights, not only placing their minds and their expertise, but their hearts in every single detail. And it's truly a joy for me to see here Dr. Dylan, whom I really have a very special love, and many wonderful people that by their professionalism and dedication are able to help patients like me. I acknowledge that Stanford Hospital has a very high standard of medical care. At Stanford, everything is taught to care for the patient. Doctors and nurses, therapists and technicians, but also janitors, like the one who cleaned my room to make sure I had a spotless place to rest. The people that prepared my food and brought it to my room, making sure that the meals were exactly what I needed for my healing. Or the musicians who came to my room to help me to relax and thinking something else to distract me. I had the great honor and joy to meet and become friends with many of them. And truly, with many of them, I still keep in touch and we text each other until today. So I was 4 months at I was 4 months in total at the hospital. And the day I was released, I left the hospital with a feeding tube in my stomach. Because of the trachea, I wasn't able to eat by myself. I left with a vacuum attached to my chest, like stick. It was like a sticker that they place with sponges, I remember. Because since I have not been able to eat for 4 months, my incisions never healed. They didn't heal completely. So they needed to drain the fluids for my skin to begin to heal. I lost almost 35 pounds and all my strength, to the point that it was incredible. I couldn't do this. Like, I couldn't stand up from my chair by myself. And I remember the very next day that I arrived at home, the hospital sent a physical therapist to show me the importance of exercise. And this story is just wonderful because as a true Colombian that I am, I love to dance. I have danced all my life. And I remember that I agreed with Jai, was the physical therapist, that he would help me to exercise for 30 minutes. And in exchange for that, I will teach him dancing lessons 30 minutes because he wanted to get back with his wife. And he did. His wife came from Hawaii and they got back together. And he took him to a place that she liked to dance. And and then, months later, they both came to my house. To me, it was just delightful. Since then, I exercise every day for 1 hour or even more. I remember Jai telling me, when I said, Maria Paula, like the virus, any virus is a microscopic being that you can expel from your body with exercise. And that was imprinted in my brain. So since that moment, I knew that I needed to exercise every day. Later, I saw it more clearly at the pandemic, and it was interesting because before 2020, before we were all confined in our house, I was going to the gym every day. I was doing Zumba, Pilates, yoga, kickbox. I was doing everything I wanted. And I was like amazed to be able to do this. Like I remember my friends, leaving the gym like exhausted, and I would leave like in awe, like I cannot believe I am able to do this. It was incredible for me. So COVID hit, and I began to walk around my neighborhood in parks also to keep that daily exercise that I needed. But of course, this was not enough. So during the year and a half that I was isolated, I lost 3 points of my pulmonary capacity. And then late in 2021, later, like around September to November, I joined Pilates, like a Pilates gym that I really like because it's just 8 people at the time. They have very good cleaning protocols and it's just very well taken care. But it was amazing because 4 months later, after joining the Pilates gym, I was able to regain those 3 points of pulmonary capacity that I lost. So for me, my experience is that 1 hour of exercise is exactly the same as any anti-rejection medication. And I have not heard this from any doctor, but I have witnessed the importance of exercise. But there is one more thing as important as keeping healthy habits like good nutrition and daily exercise. I remember listening in a philosophy conference, and I heard that the attitude that we choose to confront our life is even more important than the facts. To have a positive, I'm sorry. To foster a positive, cheerful, and optimistic attitude, help us to gain new perspective towards life, toward events, however it comes, to overcome difficulties and gain strength to keep fighting, to be part of the solution and not the problem. Truly, have a positive attitude. And I usually say, a rainy day can be awful to someone who wanted to walk that day. But to me, it's beautiful because I love plants. I have many of them. And I see my garden being watered. So the same fact, because it's just a fact, can be seen by many different perspectives, depending on the attitude. I mean, what we can control is not the fact, it's the attitude that we choose to confront that problem. And personally, what helps me to maintain this optimistic attitude is my trust in God, in his unconditional love for each one of us. Thank you very much.
Maria Paula, thank you for your sharing your absolutely, I'm muted. Absolutely incredible journey, and it was a pleasure getting to know you as well. I want to throw it over to Bob and see if we have any more questions. Or to Claire.
There we go. I had to get all my buttons pushed.
Yeah.
No, I don't see any new questions. I'm looking through both places. So Again, yeah, for those of you, I haven't introduced myself. I'm Bob Duffy. I'm formerly the co-chair of the PFAC with Elise, but I'm still a member of the group. And I just wanted to say from my perspective, just wanted to give my thanks to the speakers today. Maria Paula, that was just such a wonderful message you gave us and such an incredible journey you've been on. And, I know we've all of us who are transplant recipients, have our own stories and our own versions of that same tale that you just told. But it's always so wonderful and uplifting to hear it from others. I mean, the power of sharing our stories with each other is just another way that we survive all of this and thrive. And so on behalf of Elise and the rest of the PFAC and everyone here in the Stanford program, wanted to thank you for being here today and for sharing your story. We also wanted to thank our other speakers, Dr. Dillon and Claire Reichley, Dr. Ahern, and wanted to thank all the attendees for being here and logging in today. And we hope you found the session informative and inspiring. And again, if there are any follow-up questions, anything that wasn't covered or you think of later, you can always contact us at the PFAC, and we'll be happy to pass those along and hopefully get those answered for you. And we hope everyone here, I'm just taking one last look to see if any other questions are coming in.
Bob, I am seeing that the people are in the chat, they are asking for my blog.
I just saw that, yeah.
Yes.
If
So
you're,
if you,
go ahead.
yes, absolutely. I began this blog when I was intern to wait for the donor. The blog is called Life is Beautiful, and it's in Spanish, La Vida es Bella. So is there a way that I can type the link?
I don't know if there is. Can you yeah, I could.
Mario said that he could put it in as a link,
Okay,
and he'll
maybe,
share it with everybody.
Okay.
sure, okay.
Yeah, so
Yeah.
you're getting those messages from Mario, type it in and
Yes.
Okay, great.
So
Okay.
if you Google it, you put La Vida es Bella, comma, blog, you will see it's like from Stanford Hospital .blogspot.com, something like that. Now I don't remember the address exactly, but it's from Stanford Hospital .blogspot.com. I think so.
Okay, thank you. We also would like to thank Mario Diaz for his technical support. We couldn't have done this without you, and our other staff member, Julia Viger. It was definitely a group collaborative, and wishing everybody to have a wonderful rest of your day. I do see the link is now in the Q&A or the chat. I'm not sure, people have to check both places. But we look forward to future virtual symposiums, as well as hoping that all of you have seen our newsletter and the patient narratives that have been going through My Health. And please, if you have interest in joining our PFAC, we are small but mighty. We're always looking for new members. You can reach out to your nurse coordinator or your social worker, and we'd be happy to meet with you and let you know what we are doing on an ongoing basis. So unless anybody has anything else they'd like to add, anybody have a last minute words? I wish you all a wonderful rest of your day. And those of us in California, we're going to be bracing for some rain, and the rest of the country, perhaps some snow. So thank you again. And we look forward to seeing everybody at another town hall in the future. Have a wonderful day. Bye.
Bye-bye.